Good evening. Welcome to Heart Brothers webinar series. Thank you all for joining us. My name is Hamid Madavi. I'm a member of Team Heart Brothers, and it's a pleasure to have you join us tonight for what I believe will be a very educational and informative webinar series. I just want to do some quick introductions and talk about some basic structure and do's and don'ts just to make the webinar process flow well. So I am a member of Heart Brothers. Who we are, Team Heart Brothers, we're all patients. We're just like you. We've all had a heart transplant, and we're traveling the heart failure journey, and we've decided to give back to the heart failure community. What Heart Brothers' mission is to help and support heart failure patients and their loved ones navigate a life with heart failure and all its challenges. And for those of you who are traveling this road, you know it has many challenges. I'd like to take a moment and thank our 2022 sponsors, Transmedics Corporation, Medtronic, CareDx, Abbott, Cytokinetics, and Novartis. They are all premier players in the field of heart failure and heart transplant in different sectors. And we're grateful for their support, because without their assistance, we wouldn't be able to do some of the great things that we've been able to do. A quick rundown of what our events are for the year. So monthly, the second Thursday of every month at 6 p.m., we have a virtual patient support group. I urge and invite all of you to attend. We've had some phenomenal speakers and some phenomenal educational discussions. It'd be a shame for anyone to miss that. We have a series of webinars that we're routinely conducting. This is number 2 in the webinar. And then the third one will be March 31st, will be a joint webinar with our friends at CareDx. And it is what I wish I had known. And you're going to hear from a lot of people who've had a lot of experience on heart failure and a transplant, and share with you what they had wished they had known then when they were told they had heart failure, what they know now. On August 1st, we'll have our 6th annual Augustine Golf Classic, which is a fundraiser for us. Then on September 23rd, we'll have our Friendly Feud fundraising night, unless the pandemic again forces us to postpone it. In October, 2nd and 10th, we have our 3rd annual member for a day golf auction, where we auction off your ability to be a member at some pretty prestigious golf courses around the world. We are working with the New York Marathon Committee to field a team of 5 to 10 runners to benefit Heart Brothers Foundation at Heart Brothers House on November 6th. And on December 1st and 2nd, we have our 8th annual Team Heart Brothers Symposium meeting, where all of us gather and talk about how we can better serve our patient communities. Just want to give you guys a little bit of background. I mean, what we're sharing here in this program is based on each of our personal experiences and using our individual judgment and knowledge and those of our professional colleagues on the panel. Please consult your physician and treatment center regarding what approach and strategy is best suited for your specific conditions. This is just another disclaimer. And then some virtual meeting best practices. Please enter the full screen for a higher quality viewing. Use the chat feature to make comments, and use the Q&A feature to ask questions. Since this is a webinar, your microphones are automatically muted. You will not be able to speak, but you can communicate with us through the chat function and the Q&A session. And in the chat, if you click the drop-down menu, text 2, and select all panelists and attendees, you can communicate with them. So let me introduce our panelists tonight. It's Dr. Aderonke Adeni. She's a cardiologist that works out of University of Vermont Medical Center, and she also sees patients at Tufts Medical Center. More information about all the panelists will follow shortly, just as a highlight. Ingrid Palacios, she is works for New England Donor Services, and she's the community multicultural liaison and manager. Kyrie Miller, he's a heart failure patient. He is on the waiting list to receive his new heart, and he's priority 3. You'll hear more from Kyrie. And then last but definitely not least, Larry Williams, affectionately known as the governor, who is a heart transplant patient and a great friend and a great, basically, person who many have benefited from his counseling and from his talks and from his friendship. And we'll get to the question and answer session later. I would like to, at this point, introduce Joy Donahue, who is going to be our moderator tonight. She is a great friend of Heart Brothers. I'm really grateful that she has been able to take time out of her busy life of a new job and family and all to dedicate this time to helping us. So I've already said a lot. So with that, I just thank Joy, turn it over to her, and there you go.
Thank you so much, Hamid. Hello, everyone. Thank you for joining us this evening. First and foremost, I'd like to wish our beloved Heart Brothers, Hamid and Pat, a very happy birthday this evening. So I'm so excited that everyone's here to join us to celebrate them and the wonderful work they're doing with the Heart Brothers. Second, as a data point, this webinar is being recorded and will be available for viewing on the Heart Brothers website later in the week. So just public service announcement there. It's my pleasure to be here with you this evening, and thankful we get to have this wonderful team with us to talk about heart failure and transplant in minority communities. As Hamid alluded to, my name is Joy Donahue. I've been a Heart Brothers volunteer for a couple of years now, so I've had the good fortune to enjoy the company of many of you on the Zoom with us this evening. So hello, if I haven't seen you for a while, I'm so pleased you could join us. So enough about me. It's my great pleasure to introduce our panelists and guest speakers for this evening. This evening, we have Dr. Adeni, who is the general and advanced heart failure cardiologist who works with Tufts Medical Center Heart Failure Team in Boston and the University of Vermont Health Network Hospital System in Vermont and upstate New York. She's joining us from upstate New York this evening, I believe. Also joining us this evening is Ingrid Palacios. Ingrid has been part of the mission of saving and healing lives through organ and tissue donation for the past 10 plus years. She currently works as the Multicultural Community Outreach Program as a manager at New England Donor Services, where she provides education about organ and tissue donation in both English and Spanish. Ingrid has over 20 years of experience working with families from diverse cultures and backgrounds in several human service areas such as crisis counseling, organ and tissue donation. Ingrid has made it her life's mission to promote diversity, equity, inclusion, and belonging in all areas of her personal and professional life. And now for our guest speakers, as we all know, Larry Williams is a heart transplant recipient and a member of Heart Brothers Foundation. Larry has spent in excess of 500 days at Tufts waiting for a heart transplant and had numerous complications throughout his transplant surgery. Through all of this, Larry has been an inspiration for all of us here at Heart Brothers and is very active providing one-on-one and peer counseling to comfort his fellow heart failure and heart transplant patients. And last but certainly not least, we have Kyrie Miller. Kyrie Miller is a college student, has been managing his heart failure for 6 years. He's currently listed as a priority 3 on the transplant list, and he continues to work and attend college while battling heart failure and carrying an LVAD after surviving 4 open heart surgeries and awaiting his 5th. He thrives in spreading the message of continuing lives and not giving up on long-term goals through the transplant and beyond, while doing his best to lead by example. He's overcome many struggles throughout his cardiac journey, but he remains strong in knowing that a positive outcome is on its way, and he uses his social media platforms to mentor others and stand strong in the continuing lives mentality. So as you can tell, we have a wonderful host of guests this evening, and I think that it would be great to just jump right in. So we're going to start with Dr. Adeni. If you'd like to share your screen and bring up your slides, we'd love to see what you have to say.
So I'm going to talk about prevalence, predispositions to heart failure, the barriers to heart failure and heart transplant, how to tackle them, and how to raise awareness and why this is important. So an estimated and I apologize, everybody. So an estimated 6 million people in 2015 to 2018 had heart failure. And the prevalence of heart failure is higher in the Black population. And not only that, the prevalence of the risk factors associated with heart failure in the Black population is also higher. So this is something I was sharing that I really like us to focus on. And I'll speak more of that as we go along. And so if you look at the slide on the left side, you see that 6 million people had heart failure in 2015 to 2018, more predominant in males, still 2.6 million in females. And if you look at about the 7th and 6th row here, you see that the Black males have the highest risk of this group, and also in terms of females, they also have the highest prevalence of heart failure. So in our Black population, we have a higher prevalence of hypertension. We have a higher prevalence of diabetes. We also have a higher prevalence of chronic renal or chronic kidney disease. And there is also a genetic prevalence of a heart disease problem called cardiac amyloid. And this is generally seen in our older gentlemen of the Black population, where they develop left ventricular hypertrophy, which is thickening of the heart muscle. And they have a higher prevalence of this hereditary form of cardiac amyloid. So some social risk factors are neighborhood deprivation. So for example, if a neighborhood doesn't have exercise facilities or a park close by for our patients to exercise, if there's no store close by, that's another factor. Another factor to note is that if a patient has been exposed to discrimination at any point in their lifetime, this is actually associated with developing high blood pressure. Less education is associated with hypertension, and then less activity, which I already alluded to in terms of facilities for exercise and a walking park, is also associated with hypertension. So are there barriers to heart failure in the Black population? So there was a study, it was a behavior study, and they had a third of the patients were African American. Interestingly, the study was not supposed to focus on this group of patients, but the data team found that there was low participation after randomization in a group of patients, and those patients had were found to be the patients of African American origin. And so they thought, well, why don't we just pay attention closely to this group and get their insight into what's going on. And so that's how they focused specifically on this group. So there were 92% African American patients in this study. So they had small focus groups. They met with the patients 18 times over the space of 1 year. They wanted to know what they were learning. This was a behavioral study, and they wanted to know what factors promoted them staying in the study, what factors limited them from staying in the study. So the initial part of the study, they taught self-management skills. And then the second part of the study, they set goals. And then the third part of the study, they talked about maintaining the changes that these patients had made. And what did they find in this study? They found that if you just educated the patients, then patients were able to make choices, recognize that choices that they made would cause certain symptoms. So for example, if you taught patients that a high load salt diet causes volume retention, then if they have heart failure symptoms or signs, then they were able to correlate, this is what happened. They found that patients meeting in groups was valuable to them, and it enhanced their experience. They also found that there were barriers to patients actually attending these heart failure sessions, and some were anxiety, some of it was denial, some of it was just even logistics of getting there, and then they didn't necessarily note that compensating this patient really made a difference in them attending these sessions. Spirituality, they could not say whether or not this was also a clear-cut relationship. Some patients, their religious beliefs were important to them, and in other patients they were not. And what they did point out is that the patients wanted to have a more cultural sensitive, say, nutritional content. So they had certain kinds of foods that they liked to eat, and they wanted to have more education that was sort of channeled towards the kind of food that was culturally normal to them. So another group of patients who had dilated cardiomyopathy, they were evaluated and they were followed up for about 5 years. This is a dilated cardiomyopathy study. And this is they were looking to see if there's any barriers to getting heart transplantation. So over the 5 years, almost 4% of people got heart transplants, and then 14% of them were on a waiting list. And interestingly, there were 100 patients in the Black population in this study, and there were 25 patients, and then there were 9 patients who were not in the Black or white population. And the numbers are small, and so the authors are advising us to be careful with the results. But what they showed is out of 103 patients, only 1 patient in the Black population got a heart transplant over the 5-year course. And this is an old study, but this started to bring to light why 1 in 100 of the Black population patients got transplanted. And then in the white population, again, these are very small numbers, so we have to take this with caution. About 1 in 9 patients got a heart transplant, and then in the other group of patients, 1 in 9. But there was a 1 to 9 and then 1 to 100 difference. And then when they asked either the patients or their family members in the Black population why there was not a heart transplant, if you look at the last column and then the 6th row, about 10% of them said that it was recommended, but they were not interested. And then the next row, 82% of them said it was not recommended. There were patients on the waiting list, but there was no organ donor. That was a very low number of 5%. And then 67%, so this is the first column, and the 6th row said that they didn't have need for it. But this study just highlights a big difference between the number of people in the study and the number of people who got heart transplanted. So are there different outcomes after transplantation? So this was a registry study where there were 23,000 patients, and 20 of these patients were from the Black population. And they wanted to see if there was a difference in mortality over time, and if this mortality differed over time. So this is something I wanted to highlight. If you looked about the 8th row down on the diagnosis, if you look under cardiomyopathy, and if you look 2 rows down, you see on the Black population column, 72% of the patients had non-ischemic dilated cardiomyopathy. So this is heart failure that has no relationship with blocked arteries. But if you saw the non-Black population, that was only 45%. So this, again, alludes to the fact that we can work on risk factor modifications, because these patients are not having heart failure from blocked arteries as the primary thing. If you go all the way down to maybe like the 12th line, hypertension, you could see was more predominant in our Black patients. So if we worked on a risk factor modification, that could cut down some of this heart failure prevalence. And so what they found in this transplant group is that age 18 to 30 group, in the Black patients age 18 to 30, they had a twofold increase of dying in the first year after transplant compared to the non-Black patients. But they did find that as the patients got older, so as they were 31 to 40, that number decreased. And by the time that they reached 61 to 80 group, then there was no longer an association. And these young patients will die from either graft failure or cardiovascular failure. So this is the same plot just showing that in the younger population, you can see the curves differ, the red and blue curves. And the Black population is the red curve and the non-Black is the blue curve. And you can see the survival is lower. But on the bottom right, as they get older, this curve closes. So from this data, it just points to the fact that we need to do more studies to improve survival in the Black population, even after heart transplantation, especially in the first year. So resources in terms of cutting the barriers that we see in heart failure and transplant is we need to work with our patients from the clinical side and sort of marrying what their personal values are and helping them with self-care. So we teach about heart failure, but then we also want to know what is important to you as a patient. What are your belief systems? What are your cultural preferences? Is your faith important to you in your care? And then we also should make sure that they have good social support, financial support, and with our social work and case management team, make sure they all are able to have medical insurance. And another thing that's important in the care of our patients is to have more dedicated studies looking at the Black population. And one of them is post-transplant group. So one way to address this is a Brooklyn study where they had 94% of the patients from the Black population, and they were hospitalized with heart failure. And all of them had an appointment within 7 days, and they were given a phone call reminder. And this was to prevent recurrence of heart failure. So this part of heart failure care. What they find on the fourth line is that if you went to the clinic, your chances of being in the hospital was lower, 2% in 7 days versus 12% if you didn't go. And at 30 days, 31% of patients who did not go to the clinic for a checkup within 1 week were in the hospital. If you go back to the second line, 67% of our patients who had appointments did not show. So this shows that even though there was a resource available to help, as clinicians, I'll say we're not fully engaging with our patients. So in terms of raising our awareness, I would just like to leave with us education on the clinical side and on the non-clinical side to try and abate the risk, because most of these patients are having heart failure not related to coronary disease. So if we can optimize blood pressure aggressively, get blood pressure to goals, aggressively treat diabetes, we can also cut down risk of renal disease if we treat blood pressure and diabetes. And if we do genetic testing for amyloid, I think we'll be able to hit a lot of this risk factors causing heart failure. Again, blending our recommendations with the culture is critically important, especially building engagement with our patients, and then population-specific research. Thank you.
That was wonderful. The statistics are breathtaking, but it would seem like there's clear ways to better support the community. And Dr. Denny, thank you so much for sharing your information with us. Your generosity will afford this community like helpful information so we can work together towards a better solution. So really, really appreciate it. Thank you so much. Next up is Ingrid. If you'd be so kind and you're ready, would you please share your screen with us?
Absolutely. Let me just do this real quick. With my slides and slideshow. Can everybody see it? Okay, good afternoon, everyone. It's always an honor to join the Heart Brothers. I feel like I'm not a heart brother, but I feel like a heart sister from my heart. I been working with you guys very closely, and I so much admire your mission. So happy National American Month to everyone, and happy Black History Month to everyone here. Thank you again for inviting me. I'm gonna jump right in. My name is Ingrid Palacios, Multicultural Community Outreach Program Manager. And today I'm going to be talking about a little bit about organ donation and transplantation in our multicultural communities. New England Donor Services is the organ procurement organization that is responsible for all the surgical recovery of organs and tissues for transplantation throughout all the New England region and Bermuda. We are the oldest organ procurement organization in the United States. We were founded in 1968, and our mission is to save and heal lives through organ and tissue donation. We serve about 15 million people in the 6 states of New England and the Bermuda Island. So our service area includes 198 acute care hospitals, 14 transplant centers, and about 34 transplant programs. So that's what we do specifically in the field of organ donation. And so I'm going to jump right in with talking about these very important numbers. What is the need in the United States? So as you can see, it's almost 107,000 women, men, and children are waiting for a life-saving transplant in the US. 60% of those waiting are people of color from diverse multicultural, racial, and ethnic groups. Every 9 minutes, a new patient is added to the waiting list. 17 people die every day waiting for an organ transplant that they never were able to receive. Only 3 in 1,000 people die in a way that allows for organ donation. So that is something that is very important. Not all of us that are registered as organ donors, or not all of us that make the decision to donate, are able to be organ donors. It's very unique opportunity. One donor can save 8 lives through organ donation and can transform and enhance the lives of over 70 people through tissue donation. This is from only one person, okay? So next I want to break down who is waiting, who is in the waiting list as far as ethnicity as year to date, 2022. So our African-American community represents the largest racial group, or that is non-white, that are currently in the waiting list. Over 30,132 African Americans are in the waiting list waiting for a life-saving transplant, followed by Hispanics that are in number, 22,320 Hispanics year to date. Asian, have about 10,000 Asian and Pacific Islander patients in the waiting list. American Indian, almost 900 American Indians. Whites are 42,905 white Caucasian patients are waiting in the waiting list in the US, and people identify as multi-racial are 887 people who are waiting for an organ transplant. And so I know Dr. Adeniji touched up in this, how the African-American community is more prone, why these numbers are here, is more prone to have chronic renal failure, suffer from diabetes, and high blood pressure. So those are some of the factors on why these numbers are how they are. So what are the organs needed? As February 2022, these are the organs that can be donated either by deceased donors or living donors. And these are the numbers. The majority, as you can see, are the kidneys. Over 90,219 kidneys are needed, and these are the people that are waiting for a life-saving transplant. Livers is 11,453. Heart, 3,444, and that's just counting the heart as separate, but we also have the heart and lung combo, as I call it. For 37 people are currently in the waiting list waiting for heart and lungs. 1,059 people are waiting for lungs, and intestine 202. pancreas, 839 people, and the combo of kidney and pancreas, 19, which makes the grand total of people waiting in the waiting list right now 106,431. So these are very important numbers, but I wanted to, since we are talking about heart, and this is the purpose of this event, I wanted to share with you some heart transplantation numbers from the Scientific Registry of Transplant Recipients. And this was from 2021, and as of November of 2021, 3,611 deceased donors were able to donate their heart for transplantation in 2021. 3,111 of them were adult. Those were the adult heart transplants that were able to do in 2021, and pediatric heart transplants were 461. So you can see the numbers. I want to read all of them, but I just want to go over and highlight. There is 145 programs performing heart transplants in the United States as of January of this year. And they have here the median time to heart transplant for patients listed between 2015 and May 2020. And they say 6 months, but I know many of the Heart Brothers and many of the people that are joining us today have been waiting, or were waiting longer for the heart that they received. So I wanted to add real quick to these statistics and these numbers, the numbers specifically for New England Donor Services. Last year, New England Donor Services was able to recover 129 hearts for transplantation. We were able to transplant it from the hearts that we recover. 127 hearts were transplanted in 2021. This is for NETs. And year to date in 2022, we have been able to, I'm happy to report, we have been able to recover 16 hearts, and 16 hearts have been transplanted. So in total, in 2021, New England Donor Services was able to transplant 1,795 organs. So that was a record number also for us, and nationally, as all the organ procurement organizations came together in this mission, we were able to transplant over 41,000 organs, which was the 11th year that we had record-breaking numbers. So those are exciting numbers, but we have a long way to go. As you can see, we have a huge need in this nation. So you can see here, patients waiting versus transplants performed. This is something that this graphic shows us that, and I'm not going to go over all these factors again, because I think Dr. Adeniji touched up in all the factors that are influencing this. And then you can see how in the different ethnicities and the different races, the disparity or the gap that is in there between patients waiting and actually the transplants performed by ethnicity. And so it is important that we are all aware that although organs are not matched according to race and ethnicity, people of different races frequently match one another. All individuals waiting for an organ transplant, we have a better chance probably of receiving one of more or in larger numbers for donation if we have more donors from our own ethnicity and race, right? And so, and I know Dr. Adeniji also touched up on that, so I'm not gonna extend for the sake of time. How many people are registered? Currently, about 165 million people are registered as organ donors in the US, but only 50% of the 90% of Americans that say that they are in favor of donation are actually registered. So this is why I do the work that I do, continuing educating our communities of color to have the information and make an informed decision to register as organ donors, we really can make the difference. We need to make that difference, and all these myths and misconceptions and all these stigmas that we have in our communities of color, we're hoping to help creating programs that are culturally intelligent, that are linguistically sensitive, so everyone can have access to that information. How can you help? Register as an organ donor. I was surprised in certain events that I have done with people that have been transplanted and or are waiting for an organ transplant, that they rule themselves out and they think that they cannot be registered as organ donors because they're not going to be able to donate. You know firsthand how big the need is. So please don't rule yourself out and register. It's easier than ever now to register. Before it was that you only could do this at the DMV, but now you can register on registerme.org. It literally takes 38 seconds. I challenge you guys to do it. And also you can use for some of us that have, or most of us, or a lot of us that have iPhones, in the health app, it's also super easy to be able to register. So once you register, that's the first step. Then share your decision that you would like to save lives through organ and tissue donation with your family and friends, and your registration. Trust me, I work with a lot of donor families through the years in the hospital setting, and it helps a lot to know that their loved one had already made a decision and they don't feel there is a burden for them to like be able to make this decision for someone that can no longer communicate. So this is actually very helpful to them, and it, as many of our families have expressed to us, it provides that sense of a silver lining where they see their loved ones living on and saving lives. So please consider registering if you are not, and sharing your decision with your family and friends. Tell others how they can sign up to save lives. Share this information that you're learning today with anyone that will hear you guys. And follow us and post your stories in social media. And now, even with, especially with this pandemic that everybody has had to be, self-distancing and so on, everybody has turned to social media. We are in that era where it's important to share your powerful testimonies with everyone. You can stay connected with us in Facebook, in Instagram, in LinkedIn. This is our website. We have almost everything in both languages, English and Spanish, and also our aftercare program has several languages that we are using and providing to the community, so we can provide that equitable services and everybody can have access to the information of donation and transplantation. And so that's me. And with that, I give it back to Joy. Thank you so much for having me tonight.
Thank you so much, Ingrid. I mean, your dedication and hard work, it just continuing to support this long legacy of unparalleled support that we, the donors and recipients, have sort of the good fortune to expect from the New England Donor Services. So thank you so very much for sharing with us this evening. And now we get to move on to our speakers. First, we're going to start off with Larry. Larry, if you'd be so kind as unmute yourself and take the floor, we'd love for you to share with us a little bit about your condition and journey to transplant. Are you there with us? You might be on.
Okay, is that better?
That's perfect. Thank you, sir.
Good evening, everybody. How's everybody doing? I'd like to thank everybody besides the pharmaceutical companies and my Heart Brothers for having me on to speak. Just give you a little brief history about myself. I discovered in '98 that I had swelling, water in my legs. I had no clue, no idea. Went to a cardiologist. He said, it really wasn't nothing, but he said the guesswork's come back. About 2 days later, I'm back, and he had me run up the back of the stairs. My blood pressure was high. Then I went for a cardiac catheter, and they did it through my groin, said that my arteries were clear as a highway, but I had a mitral valve damage. So we he didn't have any idea because he had no privileges at one of the biggest hospitals. So went back and I wound up having surgery on the mitral valve, and I was doing pretty well. Then about 4 or 5 months later, the swelling started again. Went back to him, he said it really wasn't anything. So I said, well, this guy's not worried about me. So I talked to my primary, changed to, and I'll always say Dr. Marilyn Wagner at Rhode Island Hospital. She saved my life quite a few times. And she sat and listened. I had a sister at 19 that passed from cardiomyopathy. I had no clue what it was. And I told her, and she asked me, you know, I would like to bring in a specialist, Dr. Stockwell, who specializes in CHF, and they put me on stronger diuretics. And it worked for a little while. And just going on through the story, it's been a tough road. And after in 2015, July, went to Florida. And I got in my LVAD. I was really, really sick. And what happened was I called Boston, they told me come in. And they told me that I couldn't go home. My ejection fraction was like 8%. So when they told me that, I said, okay, no problem. You know, usually people will freak out and stuff. You know, like I say, in my own words, everybody else's words, you believe who you want to believe in, but I knew I had strength. I, went through a tragic loss of losing a child. And so it was very difficult, but mentally, I was prepared for this battle. And I started mentoring patients while I was on the floor and had no idea this would lead up to helping others. And it's completely changed my life completely. It was great going in patient's room, talking to them, giving them, because a lot of them asked me, how did I know so much? And I said, I learned and I listened from the doctors. I said, it's not about being black, white, orange, green, or purple. It's about being an advocate for yourself. And if you're not an advocate for yourself, nobody's gonna help you. Now, me and Kyrie, we spoke about this earlier. In the urban community, people, like we said, people get all the information from the barbershop. And it's the truth when you live there and you hear things. And then when you speak the truth, they really don't want to hear it. But after sharing my experiences with a lot of my relatives and close friends, and first thing they said, they can't believe that I've been in the hospital for almost 2 years waiting for a heart. And through the grace of God, I don't know how many times I had passed away. But the most important part that I discovered is that when I reach out to patients, everybody says I should write a blog, this, that, the other. Maybe I will, but when you speak to a patient one-on-one and you share their experience and you listen to them, I tell them, you're going through a process. I said, I'm on my journey, but you're going through a process. There's steps that you have to take. And you have to do everything you can, whatever the doctor tells you. And if you're not happy with the doctor, change the doctors. This is your body. I had spoken with a patient who has cardiomyopathy, and we discussed, I said, how long was you in the doctor's office? He said, about 5 minutes. Did he tell you what's wrong? I said, please don't hit and harm me. This is you. You can drop anytime, any place. So when you go back to the doctors, these are the questions I want you to ask. And don't let, if he brushes you off, find a new one. You know, and ever since I had became a heart brother, because of my brother Mike Ashworth, who came my way, who introduced himself to me. And we talked about an hour and a half, and I felt like I had known Mike all my life. And he explained what the Heart Brothers is about. And he had told Pat, he said, "Oh, I think we found a superstar." And to me, I'm not a superstar. The superstars are the people who are out there waiting for hearts and having a challenge each and every day. Those are the superstars. I'm there to support them, not in front of them, not behind them, but beside them. And I want them to know that. So when I speak to a patient individually on the phone, you don't know how great it feels that a patient tells you how much a difference they made in their life that they didn't know. You know, the little tricks and things. I had one patient tell me he had heart trouble and he had a friend take him by a car. I said, no, that's the worst thing you can do. Because you get to the emergency room, they're gonna have you waiting. You go by rescue. They got all your information. They're gonna wheel you right in and they're gonna take care of business. So I said, these are little tricks, you know, I show and not show, but I tell people, this is how you establish yourself. Once you're a strong individual and you know what you're talking about and you know the terminology, the doctors appreciate that because they're going to tell you, wow, you did your homework. And I did my homework when I was learning about the LVAD. I did everything I can, and I'm still learning. And I tell patients, you know, well, I died, this and that. And I said, that's in God's hands. Just keep doing the right thing that you're supposed to do, and things will work out. You know, sometimes they do, sometimes they don't. I have worked with patients that can't get an LVAD, cannot get a heart because he had testicular cancer. So that was a hard one for me to learn to work with. I worked with a stroke patient that he couldn't move his left arm and everything. He could hardly walk. He cursed me out a couple of times when I went down to his room. They sent me out of his room. But I told him the most important thing is don't believe in yourself. So ever since then, he's walked almost 1,000 feet. He's doing great. I tried, since I had COVID, I haven't spoken to any of my patients. And it's just been a little difficult. So I hope to be up in Boston next week to try to take care of the rest of this situation. But this is my story. Like I said, those who's going through it, and Kyrie, I take my hat off to you for what you have gone through. And anytime you need to reach out to me, brother, I'm there to support you 1,000,000%. I know the feeling.
Larry, thank you so much for sharing. I mean, hearing your challenging journey and knowing how much you do to continue to support the heart failure community is thoroughly inspiring. And we're sincerely thankful for you. We really, really are. So thank you. Thank you so much. And next we have Kyrie. If you're ready, please unmute yourself and feel free to start sharing your story with us.
Absolutely. It's always hard to talk after Larry. It's so inspiring. And of course I can relate to quite a bit of it. And then when you go directly at me, of course I get emotional. I'm an emotional guy. That being said, so as far as I know, on my side, heart disease and heart failure, or I shouldn't say heart failure, but heart disease has run through my family for generations, as far as I know. And, you know, unfortunately in the Black community, as Larry alluded to, you know, there's not the level of education or of awareness, you know, that needs to be there. And there are a lot of old wives' tales, unfortunately, where is, well, I'll just do this and it'll take care of it. Or like Larry said, I'll turn a blind eye to it and it'll be fine. It always takes me back to when I was younger. There's a movie called Soul Food, and I will never forget when Big Mama, the matriarch of the family, leading by example, she burns her arm, and the first thing she wants to do is reach for butter, as opposed to, going to the doctor and wanting to take care of the burn, using cold water or using ice and, things of that nature. So it definitely takes me back to that. It's a reference that a lot of people can relate to. But, that goes back to, unfortunately, in our community, we learn a lot by, going to the barbershop or word of mouth, things of that nature. So when I first started experiencing heart trouble when I was in my mid-20s, I was prescribed blood pressure medication, and I'll be honest, I kind of took it when I felt like it. I was not, the best at it. It was just, oh, I think I feel something. It's fine. I'll take a blood pressure pill. And then, a couple of days later, I'll take it. I wasn't taking it, I want to say it was I did twice a day at that point. So, I wasn't really following the regimen that I should have. And then when 30 hit, I was living back here in Boston, Massachusetts, and I would leave work. I was working as a waiter at the time. I would leave work, or I would even be in the middle of a shift, and I would start vomiting. I would be extremely short of breath. I would be doubling over, and I couldn't handle everything that was going on that, I normally could. So I ended up in the emergency room a few times, and then finally, I ended up being admitted to the hospital, and they said, no, this is something serious. Like, we really need to take care of this. I remember I was being transferred from one hospital to another in the middle of the night. And one of the vague things that I remember during that ambulance ride was I was told that I wasn't even going to survive the ambulance ride. And it was a 15-minute ride, from one side of Boston to the other. I was later discharged maybe 2 weeks later. And then the next day I was going grocery shopping with my mom. I love to shop. I love a good grocery store. Side note, I did cook you a meal any day. You all have no idea. Anyway, I couldn't even get around the grocery store with my mom. It was insane. It was insane to me. It was mind-boggling. So I ended up going back to the hospital, that day. And about a month and a half, 2 months later, I had my first LVAD. So that was open heart surgery number 1. And, that was the hardest blow to deal with in the beginning, because it was not only realizing that I had heart failure and I had cardiomyopathy and, all of these things that trickled down from, generations from before. And then it was then that it hit me that, as Larry was saying, the questions needed to be asked, and I had no choice but to learn right then and there, what was absolutely necessary to survive and to continue on. So I was discharged from the hospital, back to living life, and then the LVAD ended up becoming infected, so it was removed. Open heart surgery number 2. Actually went back to work waiting tables 16 days after that. Which I still couldn't tell you how I did it. And then I was given milrinone, which is it's a hospice drug essentially. And basically that hospital and I had parted ways, due to quite a few disagreements. And at that point, I kind of I thought that, that would be the end eventually. I had already seen the white light twice from the first open heart surgery. Yes, the white light is real. Side note, I remember closing my eyes at one point and saying, tell my mom I love her. And then everything just going blank. But, I stayed strong, and I was able to bounce back. I went over to Beth Israel with milrinone, nursed back to health. And I was able to have my third open heart surgery where they put the LVAD back in. And then as of a year ago, my LVAD actually was infected again. which is when I had my 4th open heart surgery. I actually was put into a coma for 5 days, where they rinsed me out, they washed me out. But all that to say, my message these days, I always say on my Instagram show, and in real life with people that I speak with, continuing lives. That's what these devices and these surgeries do. That's what being an advocate for yourself does. That's what, learning about the disease, being able to educate others, which is definitely what I want to do, what I strive to do. I go to work, I go to school, I have a social life. I'm able to have conversations with doctors these days to say, hey, this is what's going on, or this is what I think, what do you think? And we're able to have that conversation together. So I'm appreciative of the relationships that I've been able to build, and that I'm able to use that education and that platform. So social media is a great thing. I know Larry does it one-on-one. I definitely want to get that outreach even further. And then I would just say, nowadays, being Black History Month and the topic of conversation, it would be great, nowadays also to see, more Black doctors, especially in the cardiology field. That way then that awareness could be built more. People, of course, more so relate to people that they see sometimes. If we're also going to include inclusivity, then, let's actually have inclusivity, because, one of the slides that Dr. Donahue actually showed earlier talked about transplant rates, but to go even further in a little bit of research that I've done, it actually shows on a national scale in this country, we show statistics of people who have heart failure or are diagnosed with it. There are statistics of people who have transplants, but there aren't actual concrete statistics or data of the people who get denied of transplants and or why they get denied of transplants. So I think that that's a huge, that could absolutely bring light to the color conversation that we're having, because it's, why are these people being denied transplants? That being said, I mean, I'm thankful to be here. Like Larry, I spread nothing but positivity in my message as well. I thank you, Heart Brothers, for having me. And, I know I'm newer to the Heart Brothers family, but I am happy to be becoming a member. And I thank you guys for having me as a part of this conversation.
Kyrie, newer, but we are certainly lucky to have you. Thank you for your beautiful honesty and being, very human with your struggle and your trials adjusting to your health needs, the ups and the downs. It's breathtaking. It was really beautiful. So thank you for sharing with us this evening. We are running a bit short on time, but I do want to open up the chat for if anybody has any questions for our panelists or our speakers. I think we should probably kind of keep it to just a few, since again, we were right at the end of our time together. But if anybody has anything, I feel free to type it into the chat and I'm happy to ask. Ingrid, I think this would be a great question for you. Based on your data, can you please share some of the most common misconception about organ donation in the multicultural community?
Yes, thank you, Joy. So that's one of the, I think part of all my presentations, we're working with multicultural communities. We have a lot of similarities in what, those misconceptions and those myths are. One of them being that donation costs money to the donors. And then, we had to talk about the fact that the organ procurement organizations that actually do the organ recovery are the ones that are financially responsible to pay for everything related to the organ donation piece. That along with, the insurance of the patient, which does the transplant side of things. But so bottom line, donation doesn't cost any money to a donor or a donor family. It's, at no cost of anyone. So one being one, the most common one being, if I'm registered as organ donor, they won't save my life if anything will happen to me. And so I made an emphasis on that statistic of like only 1 to 3 people in 1,000 can actually be organ donors, because not because you die, you can be an organ donor. You have to pass in like a really specific circumstances. You had to be vented at the hospital and so on in order to be. And first and foremost, doctors like Dr. Adeniji, and the doctors made a note and to save lives. Nobody's gonna prefer one life over another. And when you get to the emergency room, nobody knows if you are a registered donor or not. Those doctors that see you in the emergency room are not transplant surgeons. They're not able or capable to like recover your organs and let you die, and they won't save your life. So there's several of these, but like I see these not only in our communities of color, but also in like white Caucasian families. This is one of the biggest fears, like, oh yes, I am pro-donation, but I don't want to be registered because people are going to be tracking me or something. So it's our organization working in collaboration with these hospitals or the type of organization that I work with, which are 57 in the country, that are actually being called and actually the ones that do the evaluation to see if you're even eligible to be an organ donor. Another one common could be, I am too old to be an organ donor. I would like to, but I am too old. We had one of our oldest donors was in her 90s. And so don't rule yourself out. You can never be too young or too old to donate. If that's something that you have in your heart, same with medical conditions. I would like to be a donor, but I have diabetes, or I have high blood pressure, or, you know, let the specialists, let the team at the hospital and let the team at New England Donor Services or the organ procurement organizations determine if there are organs. It could be 1 or it could be 6 organs that you could be donating. It can be, you know, helping so many lives. So those are pretty much, I would say, the top. I don't know if Dr. Adeniji wants to add to that, or Kyrie or Larry.
I think that you.
I just real quick is that I'm sorry
No.
that only thing like myself and Kyrie we can relate to is that when Kyrie said that, and you notice some in the urban communities, that once we take our medications, or we feel real good and we ain't gonna stop it, we're not gonna take it anymore. And I tell people that that can be a backlash, and you have to take your medicine every day. You know, they asked me, one of my patients asked, well, how many pills you take? I said, I take 40 pills a day. And he said, I couldn't do it. I said, if you enjoy life, you enjoy your family, you enjoy loved ones around you, you do what you can do. No ifs and buts about it. You know, and I say, like I always said, though, who's getting ready to go do it, it's a process. And once you get through that process, that heart transplant, and that's where the journey begins.
Mm-hmm.
Mm-hmm.
That's beautiful. Thank you, Larry. Thank you, Ingrid. I have a question here from Roger for the group. Does anybody know about groups leading advocacy to influence race-based policy? Does anybody have any?
Well, this is like the hottest topic, I would say, or trend. I am part of several groups and at the national level that are trying to influence this policy, but I know already UNOS is already working on eliminating the EGFR, hopefully I'm pronouncing that correctly, factor when it comes to compatibility for kidney transplantation. So a lot of efforts are happening. I am also part of the board of directors of the AMAT, which is the Association for Multicultural Affairs in Transplantation. So that the Organ and Transplantation Alliance, which I'm also part of, AOPA, which is the Association for the Organ Procurement Organizations at the national level, all of these organizations and more have these equity initiatives that are more than ever now even open to feedback for communities from the transplantation side, from the organ donation side, from the organ procurement side, community at large, professionals of transplantation and donation to impact policies and changes and create programs that are going to be really equitable and that are going to be key on eliminating those disparities for our communities of color when accessing transplantation.
Thank you very much. I have one last question. We're kind of pushing our time limits here, and I'm going to put this to you, Dr. Adeni. Basically, you know, education was really prevalent throughout your talk track. Is there any additional recommendations on how we can just make things better, make things more available for people who need or have questions?
In terms of patients reaching out to us, the communities, I found that there's not a lot of work that has been done in terms of maybe research, or when I looked up resources, I just could not find a lot of data on it. So that's something that I think personally wise, or just as a group, that's something that I think we need to work on, because even when I was getting prepared for the study, I could not get a lot of information and resources. So that's certainly something that needs to be worked on. Yeah.
Excellent, excellent. So first and foremost, I'd like to say thank you so much to all of our guest speakers, Dr. Adeni, Ingrid, Larry, Kyrie. Again, your generosity helps us better support the community. So your good work helps us do good work. So for that, we thank you very much for your time. In closure, I'd like to just remind everybody on the webinar with us this evening that the patient support group on March 10th, and then the next webinar is on March 31st, which is titled The Things That I Wish I Knew. We really appreciate everybody joining us here this evening. And as I mentioned earlier in the webinar, this is being recorded. It'll be available for viewing on the HEARTBROTHERS website. And a happy birthday, Hamid and Pat. And nothing says happy birthday like a donation. So as always, please be generous with supporting our community here so we can continue to do this lovely work. Thank you so much. Have a good
Thank you.
Thank you, everyone. Bye-bye.
Bye, bye, bye-bye.
Bye-bye. Thank you.
You guys rocked. You guys were awesome. Thank you.
Well,
Thank you.
No, thank you. I mean, because you know, you put this all together and you made a big difference in everyone's life. And like I said, Doctor, my one thing I would like to see us do is go to the inner community and where they have the health centers and be able to sit up and have a little forum.
A little what you said?
A forum.
Okay.
And give people an idea what our road is like and what their road can be like. And because if you ignore this situation, you know, the damage is done and it's not really much way. That's like falling off the cliff and you're just hanging on by a branch. And, you know, eventually you're going to fall. But if we can be out there in the community, like the healthcare centers and stuff like that, I think that would make a world of difference.
Yeah, you mean in educating at a community level?
Yes.
Yeah, yeah. I had a lot of trouble getting just information on resources, or so. Yeah, absolutely. Yeah, absolutely.
Yeah. Sometimes it doesn't really take resources. It's like an hour, and And like I said, if something could be set up,
Yeah.
you know, myself, I will go to a community center and sit and talk and share my experience.
You know you ain't going by yourself because you know I'm coming with you. Go
Yeah,
ahead.
I know that.
You
You
better
got
stop
twin
right
now.
now. Don't even.
All right, Kyrie, you can be my running partner next to me, okay?
Kyrie, you can be his wingman.
My wingman. Thank you there, Hamid.
Doctor, you did an excellent job. Thank you. Thank you. So grateful. You know, no good deed goes unpunished. So we're going to be calling on you more and more in the future.
That's right.
Yeah, and I'll think about what Larry has said. I really did find a lack of information and lack of data on what I was looking for. So there's a lot of work to be done. There's a lot of work to be done.
Okay, I think Emily's blowing the horn saying that it's time for us to end.
Okay,
So with that, thank you all.
bye-bye.
Bye-bye. Take care.
Thank